Right, so we discussed one method, which is to count how many heartbeats, which is a PQRST in a 6 second strip multiplied by 10. We also counted how many big boxes between two Rs or two Ps or two T waves, and then count the small boxes and then divide that into 300 and 1500 respectively. Yeah. Okay. And we proved that no matter which two Rs in the same rhythm strip, so that means on the exam, I'm not telling you what method to use because each nurse will use whatever method works for them. But you saw that we still arrived at the same heart rate, the same estimated heart rate. Okay, again, I emphasize it's estimated because it's only a 6 second strip. So the only accurate heart rate count will be a full 60 second strip. Okay. Now, chart 22-1 has several steps, but in practice, really, you don't need to do all 12. So as a beginner, all I do really are 6 steps. Okay. So yes, I would look at the rate. I would count. That's the first thing I do. I'd count the heart rate. Next is look at the ventricular rhythm, meaning I'm looking at the QRSS. And then if I'm looking at the ventricular rhythm, I'd also like to look at the atrial rhythm, which is the P. Okay. So I look at the whether or not there are P waves. Okay. So that will tell me why again. What will a P wave, the presence of a P wave tell me? Correct. That means it's a right, it's a normal heartbeat because it was fired from or initiated by the SA node. And then what's the other one? Correct. The atria truly contracted. And then I look at the ventricles. Okay, are they normal QRSs? How wide is the QRS again? Less than 0.10. Okay, so less than 0.10, or other books will say 0.12. Okay, so it's slight difference. And then are there QRSs all throughout? Okay, or are there any missing? So if there are any missing, we're looking at heart blocks. We'll discuss heart blocks probably next week. And already, yeah, we look at P waves and then we determine the PR interval. What is the significance of the PR interval again? Why does it have to be 3 to 5 small boxes or 0.12 to 0.2 seconds? Correct, because it's a pause, right? Meaning the AV node received the electrical impulse instantaneously, but yet what did the AV node do? It delayed, right? It delayed the transmission. It did not transmit the impulse to the bundle of His yet. It did not transmit it to the ventricles right away. It waited for 0.12 to 0.2 seconds. So is the AV node's role important? Very crucial. And there must be a P wave for each QRS. Okay, so if I see PQRS, if there's anything missing, there's something wrong. Yeah. So those are the 6 steps I do in practice, and that's the minimum. Okay. The action we see whenever we see a dysrhythmia, there's a age-old principle we use, that we treat the patient, not the rhythm first. I repeat, always look at the patient first before you treat the rhythm, because patients will tolerate dysrhythmias differently. Meaning, you may see VTAC, but then the patient is totally fine. They're not even aware that they're having a VTAC. They're alive. Just like hypoglycemia, are all hypoglycemics going to look the same? We just concluded hypoglycemia, right? Are all patients with a blood sugar of 59 going to be unconscious? No. Correct. So same as dysrhythmias. So patients with dysrhythmias will tolerate it differently. So what should we do first? Assess the patient. to assess them whether or not they are symptomatic. And the only way you can see that they're symptomatic is to look at the blood pressure. So we take a blood pressure. Is the dysrhythmia producing a normal blood pressure? No, no, no. We assess. Okay, we assess. Is the dysrhythmia still producing a normal blood pressure? If it is it really that serious? That means the patient is tolerating it. I'm not saying we're not going to treat it. We're going to treat it, but we don't have to panic because it is tolerated by the patient just fine. Okay, so yes, we will treat it eventually, but not this very second. All right. We look at because before we go with medications, we try to see what are possible causes of this dysrhythmia. Okay, maybe I can just eliminate that because when you look at the drugs shortly, let me fast forward a little bit. So there's a big table here with the medications. Table 22-1. Look at the side effects column. What do you see on the side effects? I'll just scroll down, okay? So just scroll through, look at the side effects column, the third column. So that's for that drug. Look at the next drug, lidocaine. You see the side effect? No, a commonality, something you see for each drug. Let me go back. Okay, they actually cause another dysrhythmia, right? Look at that. This one, yeah, prokinamide decreases contractility, so it's a proarrhythmic, causes hypotension. Okay. Lidocaine. Correct, bradycardia right there. Here, proarrhythmic again. Proarrhythmic meaning, pro means for, it favors an arrhythmia, meaning, yes, you will treat the underlying arrhythmia that you used it for, but as a result, it will cause another one. So is it really a safe drug? No, that's why we emphasize that if the patient is not symptomatic, we try to, as much as possible, find and treat the underlying cause, okay, without using drugs, if we can, right? Because we know what will happen if we give an anti-arrhythmic. We may produce another arrhythmia. Okay, so let's go back. So before we can recognize an abnormal rhythm, let's look at what does a normal sinus rhythm look like. Okay, so there's no normal rhythm. We call it actually a normal sinus rhythm. Okay. Or if you want to say sinus, that's also acceptable. Okay, so we know what you mean when you say, oh, what's the patient's rhythm? You say sinus, we are referring to normal sinus rhythm. Okay, meaning sinus, from the sinus in the AV node. Okay. So these are the characteristics of a sinus rhythm. Rate is between 60 to 100. The rhythm is regular, meaning they're occurring at regular intervals. QRS, shape and duration, normal, less than 0.10 to 0.12. P wave, there are P waves. PR interval is between what again? 0.12 to 0.2 seconds. And then there is 1 P for every QRST. That's a normal sinus rhythm. So if all are present, we have a sinus rhythm. Okay, so here's an example of a normal sinus rhythm. So on the exam, what did I say last week? If I use strips, where will the strips come from? Your textbook, this chapter, all right? We'll divide our arrhythmias into atrial and ventricular dysrhythmias. And then finally, we'll end with heart blocks or conduction problems. We will skip the junctional or AV node dysrhythmias or nodal dysrhythmias. We'll only focus on the common because the NCLEX will not test you on really complicated and severe, no, I don't want to say severe, but a complicated or rare dysrhythmias. They will only test you on the most commonly occurring dysrhythmias, okay? And as far as I can remember, when I talk to graduates who have taken the NCLEX and passed, they don't get more than 3 or 4 rhythm questions. And the questions were never something they never learned in school. So whatever we're doing is enough for the NCLEX. You follow? All right. No junctional. Okay, they're not common dysrhythmias. Okay, so only common atrial, ventricular, and conduction abnormality dysrhythmias. Okay, first, the first two will be sinus bradycardia and sinus tachycardia. Why are they called sinus?
Because they're normal, but they're slow.
Correct. They no, well, not just slow because
Slow
meaning.
and fast.
All right. Okay. So meaning they are sinus bradycardia and sinus tachycardia because all other characteristics are absolutely normal. All the shapes, duration are absolutely normal. What's the only thing abnormal? The heart rate. So in sinus bradycardia, what's the heart rate? It's less than 60. In sinus tachycardia, what's the heart rate? Above 100. That's it. That's the only thing wrong with these two. So you can say that they're the stepsisters, the evil stepsisters of the normal sinus rhythm. Okay. So what did I say were the 5 possible questions you're going to be asked on each abnormality in each dysrhythmia? What does it look like? So I'll show you a rhythm. Let's say I'll put this up on the test question, and then you're simply identifying it. What is this? All right. Second question. What are causes of this thing? So causes are listed here. It's in the paragraphs. There was a textbook before, not for this school. I remember the author was Lewis, and it was from Elsevier. They had a table with the 5 questions. So they had a table for what does it look like? So there's a strip in one column. Second column had the causes listed. Third column had the signs and symptoms. Fourth column had the interventions, both pharmacologic and non-pharmacologic. And then the fifth was the interventions. I mean, the patient teaching. It was made for you. So it wasn't available here. So you'll have to make your own table. All right. Um, yeah. Oh, I thought you were asking about the textbook. Okay. All right, so these are the causes: hypothyroidism, athletic training, meaning people who work out a lot, like me, for example. So well, jacked individuals like myself tend to have sinus bradycardia. Okay, so athletes like me have a very low heart rate. Huh? Who said it? I will send you home right away. Who said that? I have the microphone, so you're gonna listen to what I'm gonna say, okay? And not contradict anything. Who's the athlete?
You are.
Correct. So we got vagal stimulation, when you're vomiting or straining, okay? Let's say you're trying to give birth to this really big turd that can cause sinus bradycardia. Medications. So look at these antidysrhythmics here. Calcium channel blockers. Okay, we have beta blockers and other medications listed in the table 22-1. Okay, most of them cause bradycardia. A heart attack, a massive heart attack, especially inferior wall, can cause bradycardia. So that's the second question. Next question, this part is easy. The third question, which are the signs and symptoms, are really the same as the heart failure signs and symptoms. whenever we have dysrhythmias, no dysrhythmia will ever improve cardiac output. They all disrupt and lower cardiac output. So signs and symptoms here will of course be, what are signs and symptoms of low cardiac output? Meaning if your blood pressure is low, your cardiac output is low, oxygen delivery is low. So what are those manifestations? Well, this is acute though. So retaining water would be like, yeah, it take a long time. So we're looking for acute symptoms of low cardiac output, which are, yeah, mental status changes. Okay, low, yeah, hypoxia, lethargy. Okay, shortness of breath. What else? Dizziness, syncope. Okay, so meaning low oxygen to the tissues, low oxygen to the brain, low oxygen to the kidneys, which will result in oliguria, right? Okay, so those are your manifestations of low cardiac output. Interventions. Interventions, of course, is in the table 22-1. Okay. But here, look at under management. So how do we manage sinus bradycardia? Depends on the cause and symptoms. Meaning, if the patient has no symptoms, do we really need to give a drug? No, we just identify and eliminate the cause. So if it's caused by, turns out, oh, patient was trying to poop. They had the dysrhythmia, they were on the potty, they were in the toilet when it happened. So what were you doing there? Yeah, I can't, and then you see this baby crowning, okay? You just won't come out. So what do? Okay, so you give an enema or whatever. All right. So you treat and eliminate the possible cause. If, however, the cause either cannot be identified or cannot be treated right away, then this is and the patient has symptoms, then this is your treatment. 0.5 milligrams of atropine IV push. You can repeat that every 3 to 5 minutes, maximum 3 milligrams. And then rarely, if it's unresponsive, then we will do pacemakers, emergency temporary pacemaker. We'll discuss that in another section of the chapter. And that's it. And the teaching, external pacemaker. Like I said, we'll talk about pacemakers in another chapter. I mean, another section of this chapter. Any questions? MedSurg by Lewis. Sharon Lewis. Lewis. And well, let's do the same. Sinus tachycardia, what are the 5 questions we need to know? What does it look like? There you go. Here's what does it look like? Causes. Okay, causes are listed here. Please pay attention to the causes because I can pick anything random and paste it on a select all or apply question. All right. So let's say instead of saying hypovolemia, what could I put? Yeah, somebody who's bleeding, right? Or somebody who has diarrhea for like 16 times in an hour. Yeah, that's dehydration, yeah? Better keep it down. All right. And signs and symptoms, again, signs and symptoms of acute low cardiac output. And then let's go now to management. Same as sinus bradycardia, what's the management? Based on, is the patient symptomatic? Okay, based on, if the patient is symptomatic, then here are the drugs are listed in 22-1. They are usually calcium or beta blockers will be given. That's it. Or here, depending again, depending on the cost. Now, non-pharmacologic interventions are the following. Please do not do this yourselves. Vagal maneuvers can only be performed by a provider. Are we clear? Meaning don't go massaging a patient's carotid like this one. Don't do that. Okay, nurses must not do this because these are dangerous maneuvers. You do this, you could cause a rapid and dangerous drop in heart rate. and it doesn't cover your malpractice insurance because you're literally performing malpractice. Yeah, you're not supposed to do this. Okay, you're a nurse, you're an RN. Only doctor who does these things? A doctor will do this. Okay.
What's the one that, they put them, turn them upside down, let them blow in the straw?
A straw or a syringe, right? Yeah. So same thing, that's a vagal maneuver. Yeah, that's still a vagal maneuver. Cardioversion we'll also discuss on another section of the chapter because it's a whole paragraph of discussion. So we'll skip that later. So here, see later discussion. Here, IV beta blockers or IV calcium channel blockers. If the patient is hemodynamically stable, then it'll be oral. I'll put you on oral, meaning the heart rate is fast and it's sustained, meaning it never goes down, stays elevated, stays 120 over all the time. Are we gonna let you live like that without any treatment? Of course, we have to treat that because that's not healthy for the heart, right? Imagine your heart beating 120 for days, right? So you have to be given oral treatments. But for acute and you are symptomatic, then we have to give you IV to drop it down effectively. We'll skip sinus arrhythmia. That's not really common. So any question about the two evil stepsisters? All right, let's go now to we have 4 atrial dysrhythmias or arrhythmias. First is the PAC. This one's easy to spot. Here are the causes, and here is what it looks like, PAC. Now, if you look at I'll just do this because it's, so here you have a P, right? A partial P. Everybody watching this? Okay, so PQRST. PQRST. Look at this. And you can also see that there's usually a pause that, after a PAC, meaning this beat
No P.
was not supposed to, well, if that's an abnormal P. I mean, it's a P wave, but it's abnormal looking because your P waves are supposed to look like this. That's your normal P, P, P. This is not a normal P, is it? No, that is a premature atrial contraction. Again, it's easy to spot because whenever I see a pause like this one, that means a premature beat preceded it. Because usually what the heart does is it's like a hiccup, let's say you're doing this, you're talking, you do that. So that's exactly what happened. So the heart was beating and then they said, and then kind of resets, like the heart said, what the hell just happened then? And then it said, okay, I don't know. And then it went on its job. It went about its duty of contracting, right? So it's easy to spot. So this one is a PAC, and then later when we look at a PVC, it looks the same pattern. Of course, this one is an premature atrial contraction. Later, it will be a premature ventricular contraction. So that's what it looks like. Next, what's the next question? Oh, no. After what? Okay, causes. Causes first. So here are your causes. So if you drink coffee, alcohol, nicotine, smoke, what does it say here? Can you get a PAC? Yes, these are the most common causes of a PAC. So if you drink coffee regularly, you probably have PACs and you may also feel it. Have you ever had like more than 2 cups of coffee in a day or in a span of hours? And then you feel like your heart skipped a beat sometimes? You feel nervous? That's what you're feeling. You're feeling either a PAC or a PVC. Because that's the only symptom a patient with PAC or PVC will have. Hey, they feel like my heart skipped a beat. Okay? Or let's say they feel nervous. Yes and no. Sometimes again you just feel like, oh, like my heart skipped a beat. Okay, that's the only subjective sensation the patient will have. So here are the causes. You have a long list of causes there. Treatment, let's skip the table because this is the drug table. The drug table, I mean, it's self-explanatory. You have there the action of the drug. I'm not testing you the action of the drug. I'm testing you on what? The signs and symptoms. And I mean, the side effects, sorry. The side effects of the drug, meaning for table 22-1, what you're studying are side effects and what your nursing responsibilities are. What should you do when giving these drugs? Again, these are serious, dangerous medications. And when giving these, because most of these are push, IV push, make sure you know to push this slowly and then watch for the most common dangerous side effects and then what to do about it. All right. Look at the management for PACs. Is there any? Not necessary. But do we find and eliminate the cost? Yes, please find and eliminate the cost. So if it's coffee, tell the patient, hey, knock it off. Okay, so this is what's causing these, right? And because they're not really serious, PACs are not really serious. They rarely cause any problems. So it's not really cause for concern, especially if it's occurring in an otherwise healthy patient. But if you see PACs or PVCs in a patient with an extensive cardiac history, are they worrisome? Yes, you worry about it in a patient who has an underlying cardiac issue. Okay, so next serious atrial dysrhythmia are atrial fibrillation. This is the most common dysrhythmia if you hit age 65 and older. So you and me, some of us here may eventually develop atrial fibrillation. So number one cause is aging. We got old. Okay, the heart is now 65 years old, 66, 80, 90 years old. So the heart deteriorates. So now the heart, instead of just the SA node firing the electrical impulses, now it's multiple cells in the atria are firing signals as if they were the SA node. Okay, so they assume properties that they're not supposed to. So they're firing electrical impulses and now resulting in atrial fibrillation.
It's that saber tooth.
No, the sawtooth is the sister, which is A flutter. Yeah, but they have the same consequences. Yeah. Risk factors for atrial fibrillation, because this is special because this is the most common again among older adults and also the top cause for stroke. Do you want to have a stroke?
No.
Nobody does. Okay. So here are your risk factors. Age again, hypertension, diabetes, obesity, valvular heart disease, heart failure, all the way to family history. Okay. There are different types of AFib. One is paroxysmal. Paroxysmal means sudden onset and also sudden cessation, meaning it comes on suddenly, also goes away suddenly on its own. Unpredictable. And then there's persistent, meaning you're consistently on AFib for more than a week. Then long-standing in AFib for a year or longer. Permanent never converts to sinus rhythm because AFib can convert back to sinus rhythm. Okay? Again, we don't know when that will happen. Or also non-valvular. Now we have to distinguish between valvular and non-valvular because the treatment is different, specifically the anticoagulant used. Now, when you're on AFib, whether it's paroxysmal, persistent, long-standing, permanent, or non-valvular, you will be placed on an anticoagulant. How long depends on the type. The doctor will decide, not the nurses. Okay, so the doctor will decide whether or not we will put you on an anticoagulant and for how long and which type of anticoagulant. All right. Okay.
You're not gonna ask us anything about the 5 different times on the exam?
Probably not. No. Neither will I. So this is AFib. Now AFib will have different variations, okay? So again, I will only use the one you have on the textbook because AFib can present in different ways, but all of them have one commonality. There is no P wave. What you have instead are these Wrigley lines. Okay, Wrigley lines. Okay, so instead of P waves, that's what you get. Now there can be AFib that looks regular. This one obviously does not look regular, correct? Okay. So we know the causes, we know what it looks like. Signs and symptoms, again, most signs and symptoms vary depending on the severity, because the problem with AFib is it can reach the atrial rate can be 300 to 600 beats per minute, the atrial rate. Now, it's good if it's just the atrial rate, but what if the ventricles follow? Would that be disastrous? Yes, you will go into cardiac arrest for sure. So our goal for atrial fibrillation are two. So we will give the patient treatment for two. One is to control the rate, to control the ventricular rate specifically, meaning we don't want the ventricular rate to follow the atrial rate. Atrial rate, fine. If it's 300 to 600, so be it. But we have to control the ventricular rate. So rate control, and then the second is anticoagulation. We want the patient, we want to prevent stroke in the patient. Okay, because this condition will cause, because again, no atrial contraction, no P wave. Are the atria contracting? This has no P wave. So are the atria contracting? No. So what are the atria really doing? If it's squiggly like this, they're doing this too. So are they squeezing blood down to the ventricles? So what's the blood doing in the atria? Left and right atrium are pooling blood. And what will blood always do when it's hanging around in one area? It will clot. Okay. And so let's look at the scenario. If the clot forms in the right atrium, where will that clot go next? In the lung first, in the left or right lung. If the clot forms in the left atrium, there's only one place for it to go. The brain. It will be a stroke. Okay, guaranteed it'll be a stroke. You follow? Okay. So AFib can either cause a PE or a stroke. Okay. So that's the second goal. Again, to control the heart rate and to prevent clotting, to prevent a PE, prevent a stroke. That's your management. Okay. He's tired. So here are the manifestations. They may be subtle. The patient will have, for the last few months, maybe, oh, I'm just really tired. I'm short of breath. I've been, been very, like I have fainting episodes. Okay, I'm nervous every now and then. Okay, so these are the manifestations. And then what will follow, of course, is if the patient is not diagnosed, the next time they will already have a stroke. Right? We'll discuss stroke next semester. Pulse deficit is always present. What is a pulse deficit? Okay, so you have a higher apical rate, but then you have a lower peripheral pulse. Okay, so the radial pulse is slower compared to your atrial rate. What does that mean? Some of those heartbeats, did they produce a pulse? No. Meaning they were so weak that it never reached the periphery. Meaning, does that make sense? That the atria actually are just quivering. Okay, so there's a pulse deficit. Most clots in patients with AFib form in this area of the left atrium. We have a left atrial appendage. If you search online, it's like so this is your heart. This is the left atrium, yeah? There's a appendage like this. So what is it? It's like you've seen a stream or a river, right? When you're at the riverbank, are there areas wherein water gets trapped among the rocks or pebbles? Yes, right? It doesn't move, right? The water there gets trapped, and then sometimes you see fish there, tiny little fish get trapped there too. And then what grows in that area? Moss, right? You have algae because the water is not moving. So in the same way, when blood gets stuck in that left atrial appendage, what will form there? Clots. Okay. So clot usually forms in that left atrial appendage. So one of the non-pharmacologic anticoagulation measures to prevent stroke or a pulmonary embolism is to close that appendage. So surgically, minimally invasive procedure. It's called a Watchman. This is the most, there are others, but this is the most common brand. They put a Watchman patch there, closing the left atrial appendage, meaning this will be a choice for people who are, let's say, 80, 90. Is it safe to put a 90-year-old on anticoagulants? I mean, if this 90-year-old falls or hits their hand on, they'll bleed. Okay. So therefore, very dangerous. Okay. They could bleed, in their gut, for instance. They have asthma, they have ulcers. So an alternative is the Watchman. Okay. I shouldn't advertise that because there are other brands, okay, less expensive than the Watchman, but that's the most popular. So we call that left atrial appendage occlusion, the Watchman device. So how do we know you have AFib? Of course, we need a 12-lead ECG right here. And then next is we'll do echocardiogram. The preferred echocardiogram is a TEE, meaning a transesophageal. What is the purpose of an echocardiogram? We want to look for blood clots in your atria, right? We want to see, are there clots somewhere in the atria? If there are, then we better do something about it. But that's one of the diagnostic testing, because we know once you have AFib and we based on the patient's symptoms, how long have you had these manifestations? If they say, oh, past few months, is there a clot there already? Most definitely, yeah. I mean, how long has it been? It's been more than, a day. So of course, there's high likelihood that there are clots there already. Once they get break free, then you get a stroke or pulmonary embolism. Patient may not even make it to the hospital. They may die at home. Management, as I said, we control the ventricular response rate using medications listed in table 22-1. Usually it's a beta blocker or a calcium channel blocker. And for anticoagulants, the doctor will decide on how long the patient, what type of AFib they have, and then meaning if it's non-valvular, they'll use the modern oral anticoagulants, the DOACs. You familiar with what I'm talking about? Because you did DBTs last semester, yeah? Okay, yeah, so you should have discussed DOACs already. So these are direct oral anticoagulants. Remember these drugs, rivaroxaban,
No, we didn't do that.
apixaban, dabigatran. Yes, you have. You just did not remember. Edoxaban. Okay, so these are direct oral anticoagulants. Unlike warfarin, You know warfarin.
Yes.
Okay, then how come you know warfarin?
The word from pharmacology.
There's the same.
Well, we never do.
Okay, so these guys, you notice that these names have XA in them. XA, XA, XA. These are 10A, factor 10A inhibitors. Warfarin is a vitamin K inhibitor. That's why, what's the antidote for warfarin? Vitamin K. Okay. All right. So for non-valvular AFib, you can use these guys right here. They're convenient because there's no diet restriction. Because what's the restriction if you're on warfarin? Green leafy vegetables, right? So you're restricted, meaning you can still eat salad, but not like a salad bar. Okay, you can have just one, one side dish of a side of salad. That's it, no more. Okay, but if you're a salad person, I mean, it's hard if you're on warfarin. And some people, don't want to give up, what they like. I mean, if you don't eat what you like, what's the purpose of living, right? You agree? Yeah, that's the whole purpose of, I mean, you work to enjoy, right? Enjoy food. So if it's valvular in nature, meaning your AFib is caused by a heart valve problem, doesn't matter what valve, aortic, valve, mitral, pulmonic, tricuspid. If it's a valve disorder, you have one choice, warfarin only, nothing else. Why? The drug company said so. Because these drug companies, they do testing, right? They do animal testing and then clinical trials on humans. So on their clinical trials, they discovered if it's a valvular AFib, only warfarin was effective. They tried these drugs, the patient still died. The patient still had blood clots. Okay, so their conclusion, only warfarin works for valvular AFib. No particular reason. Okay, they didn't give a particular reason. It's just based on clinical trials. I know because I asked doctors already. Asked, why warfarin only? And they said, they gave me the same answer. They said, the drug company said so. So here are your antithrombic medications. Again, non-valvular. These are your choices. These guys here, no diet restrictions, no routine blood tests. What else do you need for warfarin besides diet restriction? What is required? No, what is required to be monitored?
Green.
PT, INR. PT and INR have to be monitored every week, every month. Okay, frequent drug testing. None required in these DOACs. DOACs, no routine blood testing, no diet restrictions. So which one do you want? I like the DOACs. But if you have a valvular AFib, because you have a valve problem, you have no choice. It's not, these guys here are not a choice because they're not effective against valvular AFib. I won't test this because we're not the ones doing this. It's the provider. So we'll skip this chart. And that. So here's our target. If you are on warfarin, so here's the factor 10A inhibitor. So these guys right here that have XA in their name. For the warfarin, the target is between 2 and 3. Okay, for AFib, it's 2 and 3. So that's quite high. That's your bleeding time. For DVT, it's much lower. I think it's 1.5 to 2. If you had a PE, it'll be way higher, especially if you've had more than one PE already, meaning you had a PE before and then it happened again. It'll be 3 to 4. So that's, imagine, the risk for bleeding for those patients. Okay, so that's really high. 2 and 3 of INR is already dangerous. How much more 3 to 4? I repeat, medication selection for anticoagulation depends on the patient's risk factors. So the doctor assesses their risk and then decides on which one to prescribe. Most popular among these are these two, Xarelto and Eliquis. So here's the other medications used. So besides anticoagulants, again, rate control, ventricular rate control. Choices are again beta or calcium channel blockers. Non-DHP though. So it's easy. So non-DHP calcium channel blockers, there's only two. Verapamil and Cardizem. These are the only two listed in Trade Book 22-1. Because you know calcium channel blockers, right? What do they end with? What do calcium channel blockers end with? Pril is ACE inhibitor. What do calcium channel blockers end with? Dipine, amlodipine, nicardipine, nifedipine. Okay, so those are the DHP calcium channel blockers. They're not used for antidysrhythmia. They're used for hypertension. Does that make sense? Because the DHP, the ones that end in dipine, they only affect blood vessels. They only affect arteries, meaning they only dilate the peripheral arteries. These guys here, these two, not only affect blood vessels in the periphery, but also coronary arteries. These specifically, these non-DHP, these two. Okay, those are the the ones that affect the peripheral as well as the coronary arteries. We'll discuss cardioversion. You know what? We still have time. Let's do cardioversion. Cardioversion is like, because the machine is the same. Have you seen a defibrillator? Not an AED, not the AED. The defibrillator in the hospital.
On the cross.
Okay, you've seen it, right? It's a big machine, yeah? Okay, so way bigger than AED. AED is small. So here is your typical LifePak. Or other modern brands now are the Zoll. Okay, there's a Zoll brand, but LifePak is still pretty popular. Okay, so here it is. This is the same. This is a cardioverter. We can also use this as a cardioverter. So dual function. You just need to turn on a synchronize button right there. Sync, SYNC. So the difference between the two is, let's go to your textbook now. I'll come back to this page. Okay, so the difference between, we're on page 712. So the difference between the two is the timing of the electrical shock. Right here, one major difference. Thank you for reading, Miss Sering.
In cardioversion, the delivery of electrical is like
Synchronize.
defibrillation, delivery of current is immediate and
Okay, as simple as this. So let's go back to the defibrillator. So once I apply the paddles, okay, so I connect it now. I've already pasted the paddle here. Yeah, here and here, right? Okay, so I already put it on the patient. When I press the shock button, what happens?
Patient.
The electric shock is given, right? Right away, that's instantaneously. So what do I say again before I press that button?
Clear.
Yeah. And clear, okay, clear, you're clear, everybody clear, and then boom, okay, patient gets the electric shock. In cardioversion, who are these patients that we defibrillate? Are they awake? Are they conscious?
No.
Defibrillate? You defibrillate a living, awake person?
Oh, I've seen, I've seen in the where this guy, I don't know what happened to his heart and they plug it back into it.
Okay, that's cardioversion.
Okay. So maybe I'm getting it wrong or whatever.
Okay, so we do not defibrillate a conscious patient. Are we clear? You wanna try?
Yeah.
150, 200 joules? You crazy? You're awake? Okay, so patients who are defibrillated, there are only two rhythms that we defibrillate. Pulseless ventricular tachycardia and ventricular fibrillation. You did BLS, right? I mean, I saw you there with Jim. Jim, I know, explains it. Okay, what are those two rhythms again? Ventricular fibrillation and pulseless ventricular tachycardia. Those rhythms have no cardiac output, zero, no blood pressure, no cardiac output. So is the patient awake? They're out for the count. They're dead. Okay. That's why we're trying to bring them back, right? So we defibrillate them. So they're not conscious. So are they gonna feel the electric shock?
No.
No, they're out. Here in cardioversion, the patient is alive. Okay, so the indication for cardioversion are one, AFib. Another is really high rhythms, let's say sinus supraventricular tachycardia, for instance, or atrial flutter. Okay, so really high heart rates. So we want to convert them. When we do cardioversion, the patient is actually given a mild sedative. I mean, we don't put them out, but we give them a mild sedative, okay, so that they can tolerate the electric shock. What we do is we turn on the synchronize button. Make sure you turn it on. And this is planned, okay? This is not instantaneous. Oh, let's do this right now, okay? Because it's not really yeah, it's not a life-threatening emergency. Okay, so this is scheduled. So you can say, okay, all right, let's do a cardioversion this afternoon. All right. But most cases of cardioversion, let's say if it's persistent AFib, for instance, if that's the case, we'll schedule it because the danger of doing cardioversion, if there's a clot in the atria, is when we cardiovert, what happens to the clot? We dislodge the clot. Now the patient gets a stroke or a pulmonary embolus. So when that's the case, we put the patient on an anticoagulant first for 4 weeks or longer. And then before we even do this, we do an echo, TEE. Let's look at your heart. Okay, let's see, are there any clots there? So once we see, okay, you're on anticoagulant for how long now? 2 months, okay? And we don't see any clots. So can we do this? Yes, now we can do it. Okay, let's do it this afternoon, or let's do it tomorrow. So the patient's going to receive a mild sedative. Okay, they're not given a stick. You know how when you see movies like we pull something, like we pull an impaled, knife, for instance. Are you ready? And then we have them. We don't do that. Okay, not like that. Oh, you bite on this stick, and then we'll shock you. No, we sedate them. We of course we need consent. Okay, sign consent, and then we sedate them. No mild sedative. They just do, they're in la la land, and then we perform the procedure. Make sure whatever you do is turn on the synchronize button. Turn on the synchronize button. So on the question on the NCLEX, what do you do before cardioversion? Turn that synchronize button on. So when it's on, it becomes a cardioverter. And what did it say again? What's the difference?
Yes, with the patient.
Okay, so it will synchronize with the patient's rhythm first. It will analyze the patient's rhythm and then time the electrical shock at the peak of an R wave. So it'll be a few moments, let's say when you turn the sync button on and then you press the shock button, it will not deliver the shock. It will take a few seconds because it will analyze the patient's rhythm first, and it's a computer, so it will time it. So once it analyzes the rhythm, the patient's R wave occurs every point. So let's say, every point 34 seconds. So the computer now says, okay, let's deliver it at that moment. So once it times it, and then it will deliver the electrical shock at the peak of an R wave. That usually works after one shock, but sometimes it may take a second or a third, or sometimes rarely it doesn't work at all. Right? So what's the purpose of this procedure again? To convert for cardioversions. It will convert it back to sinus. Most of the time, this will be successful. Unfortunately, a few times it does not. Any questions on the difference between the two?
Because, function is to give the shock, like. I say so every, maybe 2 seconds it shocks. Then it shocks again, like pacing, it like pace. But it doesn't-
That's a pacemaker.
On the same.
Yeah, because the same machine, this is also an external pacemaker, a temporary pacemaker. Yes. That's what you're asking, right? Yeah, we can also use this as a pacemaker. A temporary pacemaker. I emphasize temporary, okay? Because are you gonna live like that, like the rest of your life, having electric shocks delivered constantly? No. Okay, so we this is only temporary, so a few hours. Okay. Okay, let's finish AFib, and that would be it for today. I know A flutter because they're really identical. Okay, so we already discussed this. The patient will be, if the patient's high risk for clotting, what do we do again? Anticoagulant first, do an echo, and then perform cardioversion. Okay, so that's usually the protocol. Okay, the safest way to do cardioversion. So it's about 4 weeks or longer, depending on the patient's risk. Okay, here's another option, ablation. This is a invasive procedure, unlike cardioversion. So this one will destroy cells that's causing the atrial fibrillation. Well, how do we know which cells are doing it? So before we do this, we have to do what's called electrophysiology study, EPS, electrophysiology study. What is that? Patient will be taken to the cath lab, and then the cardiophysiologist, EP physician will attach multiple electrodes on the patient's chest and then analyze and locate where are the signals coming from. Which cells in the atria are firing these electrical impulses, okay? So it's an investigative, let's call it an investigative testing, okay? So they'll attach those electrodes and then find, there you guys are. And then after that, since we're already in the cath lab, put the patient into the cath lab and then thread a catheter and literally burn. That's what ablation is. We use a cautery tip to burn and destroy those cells because we already know where they are. Okay, so we'll destroy them. So that once they're destroyed, are they still gonna fire and cause AFib? no more. Unfortunately, this procedure can damage the SA node because some of those cells are close to the SA node. So if that's the case, then the patient will end up with a pacemaker, permanent pacemaker, because we've destroyed the SA node. Okay. Again, it's a rare complication of ablation, but it does happen, right? Unfortunately. And the patient is told that, so they sign consent that they assume there is a risk for SA node destruction. Okay. So here's EPS. And here's your, because again, this is a cath lab procedure. They use the same catheter, but instead of opening a coronary artery, they are destroying cardiac cells with a cautery tip. So same pre and post-op procedure. I'm not testing Maze and mini Maze. So just the common, I already explained what is the left atrial appendage. Here's the Watchman. Okay, this is the most popular brand. Oh, here's a picture. There's the Watchman. That's your left atrial appendage, and that's the mesh they use to cover it. So no more riverbank, no more appendage, no more place for the clot to form. But it's not for everybody though. Doctors will evaluate whether it's right for you or not. Okay, last one for today, atrial flutter. This is what it looks like. Unlike AFib wherein it was very erratic. Yeah, this one is very regular, very uniform. But do you see P waves? Not single P wave. So what you have are flutter waves. So earlier in AFib, we had fibrillatory waves. This one has flutter waves. Same effect, same consequence, same treatment as atrial fibrillation. So you can call it a variation of AFib. Same causes and then same treatment. So remember anticoagulation, yeah? And then heart rate control, same. And then can we do cardioversion? Same, again, same as atrial fibrillation. So here, summary, atrial flutter. Thank you for reading, Miss Elisa.
Atrial flutter is treated with anti-thrombotic therapy, rate control, and rhythm control in the same. In the same manner as atrial fibrillation. Electrical cardioversion is often successful in converting atrial flutter to sinus rhythm.
Exactly the same, yeah? That's atrial fibrillation. As we did electrical cardioversion also. Now, they specify the electrical cardioversion, which is what we discussed, using the defibrillator as a cardioverter. How do we do that again? How do we use it as a cardioverter? Very good. So you press the synchronized button. Turn that sync button on, it becomes a cardioverter. Now, there is chemical cardioversion. They're listed in table 22-1. So these are the prokinamide drugs. Okay. So this is a frequent chemical cardioverter. So you give this, it will convert patients back to sinus. You can also use cardizem right here, this one, cardizem IV drip. This can also be used as a chemical cardioverter. This one has lesser side effects compared to these guys. Okay, so these guys, they still have some calcium channel blocking properties, but these are more serious, more dangerous medications. Okay, compared to these two. So we only give them in the ICU. Okay, we do not give them on any other unit because of the dangerous side effects. Okay, that's it.